February's board meeting. I want to kick us off with not only opening the meeting up, but asking for approval of the minutes, hoping you all had a chance to review in the attachments. And Michelle, just for my purposes, since I missed the meeting and I'm listed as miss, I don't vote on this, right?
Correct.
Okay.
You can just abstain.
So moved.
Is there a second?
I'll second. This is Kat.
Any questions? All in favor?
And raise your hands, board members, so we can record your visit. And I see board member Luke has joined us as well. And everyone has their hand raised, except Singh. Singh, are you?
Yeah, I was not there, so I will abstain.
So 2 abstentions.
Thank you. So motion carries, minutes are approved. So next, Cynthia, I don't think there's any public comment period, correct?
Correct.
Great, then I will turn it over to the board committee report, starting with you, Singh.
So I was unable to attend the last meeting, but there was a presentation of of course, finance report and Office of Legislative Affairs. There were 8 findings, and we had received management's response to the findings. And unless Michelle, you or Scott feel there was anything urgent that requires board approval, I would like to get at the next meeting details on my report.
That would be fine. And just for housekeeping, if you're not presenting or speaking, can you mute yourself? Thank you. And if you're not one of the board members or not presenting, please turn your camera off as well. And that would be fine, Singh. We can add that to the next board meeting and that was a January 27th finance committee.
Thank you.
Mm-hmm.
Now you said turn our camera off or turn microphones
No,
off?
no, not you. You're a board member. You could turn your microphone off if you're not speaking.
Thank you, Singh. Next, I'll turn it over to you, Kat, for a policy committee update.
I'm sorry, you're turning it over to me for the policy committee update.
Correct.
So Michelle, this would be my first time reporting out for the policy committee.
So
how does that work? Sorry.
Thank you. That's okay. Sorry I didn't brief you earlier. Typically after the committee meetings, the committee chair just does a brief update on what was talked about at the meeting, nothing in depth. We just keep it high level so that the other board members are aware of what the committee talked about.
Okay, just wanted to confirm. Yes, so we did meet and we talked about the implications of the new administration and what we might need to anticipate and covering especially the reinsurance fund and how we might need to consider looking into using that to cover to fully cover any losses with coverage for Medicaid. So we talked about just sort of some ideas and what we need to anticipate coming down the pipe, but without having any concrete information, just for awareness.
Great, thank you. Next, Michelle, I'll turn it over to you for Executive Director updates.
Thank you. And just for the record, Board of Trustee Marie Grant has joined us as well. So we have everyone here other than Laura Crandon, who should be joining at 3. So welcome everyone. And oh geez, as I said, I think this week at our all staff meeting, there might be more bad news than there is good news this month, but we'll try and get all of it out and stay focused on the good news. Obviously, what's happening at the federal level is having a huge impact on everything we're doing. And in fact, we know that from the leadership, the new Health and Human Service Secretary is Robert F. Kennedy Jr. He was put in place. That now has kind of started some snowballing of some things that we're starting to see. We are waiting for Dr. Oz to be confirmed as the administrator of CMS. The CISIO, which is the Center for Consumer Information and Insurance Oversight, which is the area the exchange reports under. The new director of that is Peter Nelson. So we don't know a whole bunch about him other than he was in the prior administration. And my understanding, he's very favorable to 1332 waivers. So we look forward to discussing that with him. We also think, and I'm not sure if this is confirmed or not, and perhaps Secretary Herrera Scott knows that CMCS, which is the Medicaid side, where Medicaid reports up, Drew Snyder is set to be that director. And I don't know if that confirmation has occurred yet or not. So that's the latest we know on that. So that's kind of the landscape of what we're seeing. As you probably heard in the news over this past weekend, DOGE has now come into HHS and is starting to look around. My contact that I work with, I just got a text from her indicating that 4 of her staff have already been let go. So again, she's reaching out saying, are there any openings in your shop? So we're going to start to see more of this. We don't know what that means, but we will, continue to look for how we can support our partners at the federal level who we know are going to be displaced. The other area that we're keeping a close eye on are the executive orders that have come out. February 11th, there was an executive order that came out putting a reduction, or the 14th, I believe that was, reduction in the Navigator funding for the federal marketplace, reducing it to $10 million. Now, what's most important for the board to remember and for Maryland to remember is that because we are a state-based marketplace, we fund our navigators ourselves. And so we are not, that doesn't affect us what the federal government does. However, having said that, we'll see what happens on the state funding shakeout. But right now, from that federal reduction, there won't be an impact for our navigator program. Let's see. We also know that there's a close look at reducing Medicaid funding. We've heard President Ferguson talk about that in the state of whether that funding gets reduced from 90-10 spending down to 50-50 spending. Board member Tenasia sent around an email asking what the impact to that would be. It will be a significant impact. First and foremost, it will impact consumers that if the state, and I don't know how the state would backfill all this funding, but if they were not able to, it would significantly impact consumers. How it would impact the exchange is we do get funding from Medicaid, from CMS for the Medicaid work that we do. And in fact, for our IT work, there's a lot of work that is 90-10. Other work we have is 75-25, other is 50-50. Any cuts to that contribution will likely mean a cut in our staffing levels, mostly on our contracted staff, and then our ability to get the work done along the same timelines that we have been able to get them done. So we may see some significant disruptions there. The other area on federal is that there was, this is more in legislation. There was a bill that is passed now through the House, HR 77, which is called Midnight Rules Relief Act. And what this would allow Congress to do in just one fell swoop, reverse anything that had been done in the prior 60 days from rulemaking. And so 2 of the things that would be impacted, that one's actually on the executive order side, would be the DACA that we have provided for DACA recipients, that coverage that could be impacted, as well as the 2026 Notice of Benefit and Payment Parameters, which sets out kind of the landscape for the individual insurance market and the carriers on what those parameters will be for that year. So that could get changed. Those are just things we're seeing. Other threats that we're still keeping an eye on is the impact of the Maryland State Reinsurance Program. We don't know how any tax credits might get reduced. We have the expanded tax credits, which came out through ARPA and the Inflation Reduction Act. We know that those are set to expire at the end of 2025. We also know that it looks like March 13th will be a critical date in the federal government. The 14th, I think, is when we're due to run out of funds to keep the federal government operating. And so there's budget bills coming from the Senate and the House, and we'll see what happens with that expanded tax credit, but that would affect the reinsurance program. It would affect our enrollments. So it would have a lot of issues. So right now we are just, you know, I'm liking it too. I'm in the ocean and a big wave's coming over me, and I'm just kind of crunching down to see what's going to come over and then where things are going to land. And then we'll go from there. We'll stand back up and we'll regroup from there. So that's the worst news of the day. The better news that I'll share is that on the state front, we obviously it's a really tight budget season. We've been preparing for that as an agency. We are working with the state in different areas. And in fact, we had several months ago when they started the budget process, DBM rolled out, it's called Results for America, and really looking at how we can do what we do better and really put in objective measures of how we put out contracts, whether it's with our navigators, whether it's with our call center. And so we actually have worked with them on making sure that what we are doing and looking for services is making it very evidence-based and meaningful and outcome-oriented. Just recently, we worked with, again, another initiative out of the governor's office, and I applaud Governor Moore for doing all this, looking at how we can get efficiencies with our call center and with other call centers. So we've spent a lot of time explaining that the Exchanges call center is really not a typical call center. There are more caseworkers at the call center, have had great meetings with them, and really, I think we're able to demonstrate the ways that we already are very efficient with the dollars that we get and how we use them. So they were quite impressed, and we'll be having some other meetings with them. So we're looking at everything from our meetings in Annapolis. The agency is very well respected and very well liked, and we will continue to work on that path. So again, we thank the board for your governance and letting us get there. And then finally, the other thing that I want to talk about, which is a big ticket item, is our Office of Legislative Audits audit. And this probably was the worst experience since I've been with state government of going through an audit, just in terms of the time. It took about 18 months to go through. It's a triennial audit, and it took about 18 months to go through, even though a lot of it, there was no one on site. There are several findings. We are working with OLA, and I expect that these will be brought up at our budget hearings. Probably the biggest one, which is again in line with what the federal government, where their position is during the audit period was from 2020 through 2023. That was right during the pandemic. That was when Medicaid was not allowed to stop coverage for people. And one of the findings from OLA, and it has been a repeat finding, is that we allow attestation of income for Medicaid. And we have worked with our colleagues at MDH, and we've drafted our responses collectively, that is the federal law that we follow. So we will continue to try and explain that. And we may probably see something different coming out of the federal government anyhow this year. So we'll keep an eye on that. Other things, you know, not substantial things that we have worked with, already implemented or made changes or following closely through. So that report is public. You can all go out and look at it today. It is public. And then I'm just going to close with some more positive news. We are, the check the box is in the process right now. And so anyone who's filing their taxes, if you don't have health coverage, and you want to have health coverage, check that box and we'll reach out to you and help get you health coverage. And then just some really, really heartfelt, warm wishes to 3 folks on this call who are moving on into other roles. So Sharon Merriweather is moving into a new role at the Attorney General's office. So we wish her much gratitude for what she's done, and really will be under her arms still. So we're happy about that. Ben Steffen, who eventually is going to retire, I think within the next month or so. So Ben, thank you for all the work you've given the state for so many years, and we will certainly miss you. And then our fearless chair, Laura Herrera Scott, who just came in running fast and furious to get us, keep us going on track, and with real good collaboration with MDH and vision and foresight. And she will be leaving us the end of this month. So we wish you much gratitude and wellness as you move on as well. And I will stop there. If anyone has any questions, I'm happy to take them.
Thank you, Michelle. Does anyone have any questions for Michelle and her update?
I have a comment, kind of a request, but you don't need to follow it. DOGE, please do not say Doge, because Doge means Chief Magistrate in Italian. DOGE, don't give that to them.
Thank you.
Anyone else? Any questions for Michelle? And Ben, certainly I want to acknowledge your service to the state and all the great work that you've done leading MHCC. It's my second go around with you, and it's just been an honor to work with you. So thank you. And Sharon, good luck. Good luck. And with that, we'll turn it over to Aika and Johanna for the Standing Advisory Committee member approval.
Thank you. I'll go ahead and kick us off, and then Joanna, feel free to chime in if you want to add any color. So on the next slide here, I mentioned in our last meeting that we were in the process of getting applications, new applications. And since then, that time and application period has ended. The application was posted on December 16th and ended January 31st for new applications for folks to join the Standing Advisory Committee. The Standing Advisory Committee is charged in Maryland statute, which is addressing a broad range of policy issues on which the board may seek its input and advice. And so to the extent is really reflective of the gender, racial, ethnic, and geographic diversity of the state and diverse cross-section of stakeholders. And SAC members serve about three-year terms. And so the application and member recruitment process was consistent with MHBE SAC policy and procedure. And to the right, you'll see a chart of sort of our applications, and we'll unpack a little bit more of who those new members are. The application was posted on the MHBE website, shared with current SAC members, and the MHBE staff conducted targeted recruitment. So based on the makeup of the SAC members whose terms ended in 2024, recruitment goals were around, particularly for 2025, were centered on increasing recruitment for the Eastern Shore and Capital regions. Staff conducted targeted outreach in those areas, and we ended up with 2 applicants from the Eastern Shore and 4 from Capital North and South, so Prince George's County and Montgomery County. And so on this next slide, we'll go into a little bit more of the new applicants. And so recruitment goals, as I mentioned, were focused on geographic diversity, but also diversity of professional specialty. And so the cohort of 2025, we had 11 applicants, and it was a wide range of representation, including community organizations, healthcare providers, public health researchers, brokers, navigators, and insurance carriers. MHB staff generally aim to recruit about 6 to 8 new members each year. However, we had a lot of SAC members whose terms ended early, whether they were leaving the state or leaving their professional affiliation. And so we had a larger recruitment goal for 2025, and we have 8 non-carrier applicants. And so SAC traditionally includes representation from each carrier that's active on the Maryland Health Connection, including standalone dental carriers. And so in 2024, the stack terms for the current representatives from Care First and United Healthcare ended. And then additionally, MHBE invited WellPoint to join the committee as they newly entered the individual market for 2025. And so as a result, we have 3 applications from carriers, which are Care First, United Healthcare, and WellPoint. 11 is, as I mentioned, it's a large pool of applicants, so we're recommending 10 to be appointed to SAC. Particularly, there were 2 broker applicants, one from Central Maryland region, which is already heavily represented in our SAC rep membership, as well as this particular round of applicants, and one from Eastern Shore. And just given the priority area of that geographic location for new member recruitment, our recommendation is to approve the broker, particularly from that region. So on this next slide, I'm going to go into a little bit more detail on each applicant. And so here gives you the sort of makeup of the folks that we are recommended as new applicants. The asterisk by the first name is who we're representing. Like I mentioned, given the priority and geographic region, we are recommending the broker who's part of our particular geographic space of focus. And so that's why there isn't an asterisk by Shaloma Rosenstein. But the others who have asterisks by their name, those are the individuals that we are recommending to move forward, considering our particular geographic and specialty recommendation needs. And so that brings me to the next slide, and a motion to approve the appointments of the new members to SAC. So Joanna, I'm happy to turn it over to you if there's anything else you'd like to add before questions from folks in the motion.
Covered it. Thank you.
Thank you.
Any questions for Aika? Okay, I move to approve the appointment of the applicants to the 2025 Standing Advisor Committee as presented. Can I get a motion to approve?
So moved.
Thank
Ben.
Second,
Thank you, Singh. All in favor?
aye.
Okay, I have everybody. Thank you.
You have everyone? Go ahead, Dana, you have your hand up? Oh, your hand was just up for the vote. Got it, okay. And Cynthia, was that everyone, or were there any hands that stayed down or any,
I have everybody raise their hand.
okay, then the motion's approved. Thank you all. Next, I'll turn it over to Johanna to go over the 2026 final plan certification standards.
Thank you. And I think this will be pretty quick. We can move on to the next slide. And one more. So we've got two standards to share with you, but this is really a repeat of the presentation that you saw previously when we shared the proposed standards, because we received no comments during our public comment period on these proposals. So we're just bringing them back to you as initially proposed and as you had approved to share for public comment. So I'll just do a quick recap and to refresh your memory. And as a reminder, these kind of go through an extensive process before they even get to the board, which is, I think, why we don't have any comments at this stage. The value plan standards that I'm going to share were workshopped with a work group that includes all the carriers and other key stakeholders, and were unanimously recommended by that work group. And our proposed standards also go to the Standing Advisory Committee for feedback before we bring them to the board. Next slide. So just a reminder for our value plans, carriers offer one value plan at each of the bronze, silver, and gold medal levels, and then they can offer 2 plans of their own design. MHBE establishes the plan design, which is essentially the cost sharing that applies to each benefit, because the benefits themselves are standardized already. And so we establish that cost sharing. And as I mentioned, we do that with the help of a work group. Next slide. As a refresher again, so the changes for 2026 compared to the plan designs that we had from 2025, and these are driven both by work group input and by changes necessary to comply with the actuarial value calculator by the federal government, which is the calculator that's used to measure plan generosity to slot a plan into each medal level and is updated each year, and correspondingly requires typically updates to cost sharing each year. So most of this is driven by federal compliance requirements. But so the updates that we had proposed were to reduce the lab copay in bronze and a couple of our silver variant plans. This was pursuant to feedback from the work group that lab copays are particularly important for individuals with chronic conditions, which often are in populations that have health disparities. And so reducing that copay was the primary recommendation of our work group and to improve affordability this year. So we targeted that where we could. The other changes were to make some technical tweaks to our pediatric dental coinsurance to better reflect how dental services are grouped together in the commercial insurance market, to increase the maximum out-of-pocket amount across the plan levels. This is the cap on the most out-of-pocket costs that someone could pay in a year. After someone hits this max amount, the carrier will cover 100% of their costs for in-network covered services. The exchange and carriers generally look to increase the maximum out of pocket first when they need to adjust cost sharing, because only a small handful, around 2 to 5% of enrollees, will hit this high dollar value. So it's a way to meet the federal compliance standards while affecting a smaller portion of enrollees. We also increased the specialist copay from $100 to $110 in our bronze and a couple of our silver plans, raised the lab copay from $5 to $10 in one silver variant plan. I know that's a little opposite of our overall drive to reduce lab copays, but we played around with a lot of options, and this was the one that had the kind of most bang for our buck in terms of being able to meet our federal actuarial value requirements without having to make a lot of other changes that we discussed with the work group and deemed would be more impactful to consumers. And then the last was to slightly raise outpatient rehabilitation and habilitative services copays from $2 to $5 in our most generous silver variant plan. Again, this is more of a technical fix. We've learned these copays are typically aligned and the services are very similar, if not the same, across these service categories. So it makes sense to have a standardized copay, and we do in all of our other plans. It was a little bit of an oversight that these copays got misaligned just in this one plan. So those are the proposed changes. Next slide. And I think we'll just speed through these changes, but these slides, you've seen them previously. They detail each covered service and the proposed cost sharing with the changes highlighted in yellow. Next slide. You can go on to the next one as well. And then this slide highlights our ongoing provision of $0 services for commonly used services by individuals with a diabetes diagnosis. So this was a standard that we started for 2025 and would be continuing for 2026. So there's a typical service kind of array here for those individuals with diabetes. And I think that's it on the value plan slides. Yes. So then I'll just briefly cover the one other proposed plan certification standard, which is to require equivalent cost sharing for primary care and mental health and substance use disorder office visits, and to encourage carriers to use a copay structure for those service types. As previously shared with the board, this is to kind of simplify the cost sharing across these service types. We can go on to the next slide. There are state and federal parity laws that generally require financial requirements across mental health and primary physical health to be equivalent. But again, these can, because of the technicalities of the law, they can actually have different cost sharing amounts and still kind of be within their legal right to do so. However, we felt that it would be simpler from a consumer communication standpoint to make these cost sharing amounts equivalent, and would also be beneficial to consumers to promote access to mental health and substance use disorder services. So I'll leave it at that. And again, we got no comments. So I'm happy to take any questions on these.
Are there any questions for Johanna?
Johanna, can I ask you just to address two things that comes up all the time? One is the maximum out of pocket. And I know we've done an evaluation of how many consumers actually hit that maximum out of pocket, because that's always a big number. And then second, because of these plan certification standards, we've seen, you know, a significant amount of people on gold or platinum level plans. I think that would be important for the board and the public to hear.
Yes, thank you. Happy to address those items, Michelle. So yes, we worked with the MIA and carriers a year or two ago to look at how many consumers hit their maximum out of pocket amount, which is a substantial dollar figure. That's about 2 to 5% of enrollees per year hit that maximum out of pocket. So that's why when we're toggling financial levers to stay within the actuarial value requirements, we and carriers typically will bump up that maximum out of pocket threshold, because it is that smaller 2 to 5% of enrollees that it affects. That maximum out of pocket limit, there is a maximum out of pocket that's set by the federal government and increases slightly each year. It's indexed. So our limit is always at or below what the federal maximum threshold is, but the whole kind of industry typically sees that maximum out of pocket inch up each year just because of the actuarial value requirements. And then in terms of the distribution of our enrollment across metal levels, we are happy to say that almost 75% of our enrollees are in gold or gold equivalent or better plans. So our silver plans have some variants that make them equivalent or better than a gold plan, and almost 3/4 of our enrollees are in those more generous plans. So when we're looking at the bronze and silver cost sharing amounts in our value plans, we can kind of know that we have very few people enrolled in a base, what's called a base silver plan at the 70% actuarial value level. Most people are enrolled in a more generous version that they qualify for because of their lower income. And then we do see about 25% of our enrollees in a bronze plan. And we do know that you know, there are healthy individuals who have low claims, and a bronze plan may be free or nearly free to them. So they're taking, you know, maybe taking a calculated decision to choose that bronze plan, have very low out of pocket premium costs because they anticipate having low healthcare spending.
Thank you, Johanna. Any other questions? Okay, hearing no questions or seeing hands raised, I move to approve the final plan certification standards for plan year 2026 as presented. Can I get a motion to approve?
So moved.
Thank you, Dana. Second?
Second.
Thank you, Aika. All in favor?
Aye.
Okay, hi, everybody. Thank you.
Thank you. Okay, we'll move on also to Johanna to hear about the 2026 estimated reinsurance parameters.
Thank you. And you can zoom through these appendix slides. Yeah, there we go. All right, thanks. So just a reminder of our regulation. We started this presentation off every year with this slide. Our regs require the board to set estimated payment parameters for the reinsurance program by April 1st every year for the following plan year. So we're looking at plan year 2026 parameters this year. And that's to provide carriers with figures to include in their rate filings. So when they make those rate filings, as they prepare those rate filings and then file them with the MIA, they have an assumption on what to use for reinsurance for the coming year. Next slide. So just some key dates. Today, we're working with you to set the estimated 2026 reinsurance parameters. And then the next board action would be in July. We always come to the board in July to ask the board to set the final reinsurance parameters. Between now and July, we will get carrier claims data and for 2024. So prior year, they have to do some claims run out, and that gets submitted to the federal government, and then the federal government shares that information with us, and we also collect information directly from carriers. So we know both what we will be paying out in claims for 2024 under reinsurance, and typically we also know what we will be receiving from the federal government in pass-through funding for this year, 2025. So when we have that additional data, we can do some more modeling with our contract actuaries and consult with the MIA to come up with recommended final parameters for the coming year. So we'll do all that data analysis between now and July and come back to you with that final recommendation in July. And then that those parameters will be incorporated into the carrier's rate filings and used as they work with the MIA to finalize their rates over the summer for 2026. Next slide. So just a few key terms to recap here. As most of you are familiar, the reinsurance program is operated by MHBE under a waiver that we received from the federal government. It allows us to reimburse insurers for a portion of their claims, specifically for individuals who have relatively high claims costs. Those lower claims, because we're covering a portion of them, and it works out to be about 1/3 of carriers' claims, allow the carriers to lower their premiums concomitantly by about 1/3. And it's been very effective. Rates are now more than 20% below where they were before we had the reinsurance program in 2019. And then a few key terms about reinsurance. The first one is the attachment point. So when the enrollee's claims exceed the attachment point, which was $20,000 for many years and has been just started to move up, then the reinsurance program starts reimbursing the carrier for a percentage of claims above that attachment point. The percentage that we reimburse is called the coinsurance rate, and then we reimburse that percentage above the attachment point until the individual hits the cap, which is the reinsurance cap. So if we move on to the next slide, we'll have some concrete figures to apply these terms to. So you can see here in the first column in this chart, from 2019 through 2022, we had the same three parameters. We reimbursed 80% our coinsurance rate of claims for an individual if they had claims above $20,000 up to $250,000 in a year. Above $250,000, the carrier is responsible for fully paying all of those claims. Below $20,000, again, the carrier pays all those claims. But if someone has claims in that midsection, the reinsurance program covers 80% of them. In 2020, for 2025, we started inching that attachment point up from 20,000 to 21,000. We had a little dip in 2023 in consultation with the MIA and the attachment point to counter some premium increases that we were seeing and help stabilize the market. That was just a one-year adjustment. In 2024, we went back to 20,000. In 2025, we went up to 21,000, and we have our modeling assumes a $1,000 increase each year going forward from here. That increase helps to keep the reinsurance program at a consistent scope each year because, of course, with inflation and medical trend, costs increase each year. So if our attachment point were to be perpetually fixed at one level, we would gradually be covering a larger and larger slice of the pie of claims. So we do want that to move up year over year. And the last item I'll mention here is a dampening factor. The board does not set the dampening factor, but the board determines if a dampening factor is necessary. And if they make that determination, the insurance commissioner selects the dampening factor. The dampening factor is an adjustment factor to reinsurance payments that Maryland makes to account for the interaction between our state reinsurance program and the federal risk adjustment program, which is another federally administered program that moves money between carriers to try to equalize risk across the market. There can be sort of duplicate reimbursement for individuals who qualify both for reinsurance and risk adjustment payments, so as to not amplify that duplication. We employ the dampening factor, which adjusts for that. And we have had one every year. We go through a process with the MIA to determine, and our contracted actuaries to determine what an appropriate factor is. And we'll come back in July typically, or perhaps subsequent to that, to let the board know what that factor is. But for now, we do recommend the board continue to determine that a dampening factor would be necessary for 2026. Next slide. So this is a snapshot of the funding outlook for the program, and this is based on data collected through last summer. So this will be consistent with what you saw last July. When you set the final 2025 parameters, we'll be getting the data to update this over the next several months, and we'll share an updated version with you this July. But based on, you know, the most current data that we have as of this moment, you can see the green and the blue bars represent the funding that the state receives each year for the reinsurance program. Green is our federal pass-through funding. Blue is the state funding we receive through our 1% assessment on most health insurance premiums in the state. The red line is our annual cost of the program, so how much we're paying out to carriers. And the purple or kind of blackish looking line is our fund balance. So you can see for a number of the years from the start of the program, 2019 through this year, we have received more funding than we've ended up spending on the program. And so that has allowed us to save some funding in our fund to use in future years if and when our annual funding is less than the actual cost of the program. And we do project that you can see in 2026, the federal funding, the green bar dips down, and the red line, the cost of the program, will exceed the amount of funding that we're bringing in each year in 26, 27, and 28. So we'll be drawing down on that reserve. And you can see the reserve declines from 2025 through 2028 as we draw down that funding. We still anticipate that we'll end this waiver period. We have 5-year approval periods with the federal government to operate the program. So this period ends at the end of 2028, and we still anticipate we'll end with a balance of $263 million. So we would be solvent. And these assumptions, as I mentioned, assume that that attachment point increases by $1,000 a year from 2025 at the 21,000, 22,000 for the attachment point in 2026, and so on. The last thing I'll mention about this chart is the reason for that drop in federal funding starting in 2026 and future years is because we are assuming that the enhanced premium tax credits from the American Rescue Plan Act end at the end of 2025, as they do under current law. So if those aren't extended, one of the impacts is that our federal reinsurance funding would decline. So that is why we see that decline and would be drawing down on our reserves. So that is, I think, the last slide there, but I'm of course happy to take any questions. Oh, and then just in terms of next steps, once these estimated parameters are set, we have a public comment period. I mentioned we collect additional data and then we come back to the board in July.
Marie raised her hand.
Go ahead, Marie.
Thanks, Cynthia. Thanks, Madam Chair. So Johanna, can you go back to the chart for just a second? Thank you for this presentation. So I just wanted to clarify something you said for 26. there's an estimated almost $100 million lower spending in reinsurance. Can you talk a little bit more about that? Because of course the subsidies will go away, but the enrollment mix. Just curious about what the thinking is behind that estimate.
Yeah, so there's both a drop in the funding and the spending, as you're pointing. And so I think that ties back to an assumed change in the enrollment mix, as we do see some individuals who are receiving APTC drop coverage as that APTC becomes less generous and they have to pick up a larger portion of their premium. So we anticipate enrollment declines, which has the impact of also reducing reinsurance costs, but also reducing the funding.
Then the next thing, maybe just a comment, is just I think I'm appreciative of the fact that this is going to be a little bit of an iterative process for the next few months. I think that's extraordinarily important in a time of uncertainty. So just look forward to working with you all on this process. Thank you.
Any other questions? Go ahead, Singh.
The attachment point increase of 1,000 annually, how much is that impacting here, the state funding part of it? And also how much of that is impacting the fund balance reserve, which we're depleting pretty fast actually over here?
So we can provide what the difference would be between the $1,000 increase and no increase, but the increase in the attachment point does reduce the cost of the program because we're covering a little bit a smaller share of claims. So by increasing the attachment point, we do extend the solvency of the program, we reduce the reinsurance cost. And we have previously looked at what is the impact on rates of $1,000 increase in the attachment point. My recollection is it's about a 0.5% increase to rates to do that reduction. So we want to balance both kind of preserving state funds, but not increasing rates, you know, in a way that would impact the market too much in any one year. So as Marie said, we're going to be continuing to get data on what is our funding this year, what is the fate of the enhanced subsidies, how does that affect the funding outlook, and so we'll have a lot more information to inform our recommendation to the board in July.
Are there any industry comparables, you know, what we have versus other states, other places?
Yes, we worked with the MIA on a report last winter to look at our reinsurance program and make recommendations to the state about whether the state should consider any changes to it. And part of that involved looking at all of the other state reinsurance programs. So we can definitely send that out to the board and pull out those comparative analyses. We do have one of the most generous reinsurance programs with one of the lowest attachment points nationally. So we are covering a larger share of claims and we therefore have a higher cost program than many other states. But I would say that hand in hand with that, we see that there's sort of a positive relationship between the size of the program and federal funding. So we get a larger percentage of our program covered by federal dollars than do states that have a smaller reinsurance program. And we also see the direct impact of the size of our program on premiums. So it's really large, in large part due to this program, that we have the lowest cost bronze and gold plans nationally and one of the lowest cost silver plans.
If I may, if we, you know, today approved, for example, these plan rates, and as board member Grant mentioned, next few months, you know, we don't know what will be happening. And if in next few months, we find that we have to shift our reinsurance cost or some other, will there be an opportunity to reset these, or these are locked in for fiscal 26 going forward?
There will definitely be another opportunity. So these are just estimated parameters for the purposes of carriers' initial rate filings. When we come back in July with our final recommendation, that's when the board will actually lock in what the 2026 attachment point, cap, and coinsurance rates are for 2026.
Thank you.
And Johanna, to that point, so as you think about, you know, the points that we're talking about now, I mean, are you playing with the purple line to see how the purple line moves up or down, right? You know, I know we're trying to keep costs down, but versus not having a program that's funded adequately. So how are you looking at that piece? Or is that the discussion that's going to happen from now into the summer?
Yeah, that's what we'll be looking at between now and July as we get the final information on what our 2024 payments will be to carriers and what our funding from the feds will be this year. Then we'll have that new information to update this whole chart and then start tweaking parameters to bring recommendations and options to the board in July.
Are there any other questions for Johanna?
Secretary, I have one question, Ben Steffen. So Johanna, I just wanted to confirm that the federal revenue estimates for 2026 and 2027, they're I guess, they presume that the IRA subsidies would be gone.
Yes.
Just want to be sure for the board that you understand that this is kind of it's definitely not a rosy scenario. It's a pragmatic scenario at this point. Is that correct?
That's correct. Yeah, I mean, if the subsidies are extended in whole or in part, we expect this picture to look better. Our federal funding would increase and our drawdown on reserves would diminish, or perhaps we might not need to draw down on them at all. So this is a conservative
Thank you.
snapshot for now.
And then just to add one other thing to this, you see this program goes through 2028. That's where our current waiver goes through the end of 2028. We will have to be making decisions in 2026 about the future of the reinsurance program as a whole, because we will need the legislature to approve us submitting for another waiver. We'll have to have some serious discussions at the state level about funding for this program, how to use this program. Is it still the right program? So 2026 will really be a big year for us in evaluating and looking at what happens after 2028, because there are some timelines involved with resubmitting the waiver. And we'll also be starting those discussions, as I mentioned, the Director Nelson, to kind of feel out what the federal government, how they're feeling about waivers. So a lot more to come next year on this as well.
Thank you, Michelle. Any other questions for Johanna? Okay, so I'm going to make a motion to move to approve the estimated parameters for the 2026 state reinsurance program as presented, with an attachment point of $22,000, a coinsurance rate of 80%, a cap of $250,000, and a dampening factor to be provided by the insurance commissioner. Can I get a motion to approve?
So moved.
Second.
Was that you, Aika? I didn't see I couldn't identify the voice. Cynthia, did you get who's second?
I didn't
That's
second.
Kat.
No, I did not. That was Kat.
Oh, okay. Thank you, Kat. All in favor? Aye.
Aye.
Okay, hi, everybody. Thank you. Michelle, you're on mute,
Oh, sorry. For the record, Board Member Crandon has joined us as well.
and I have everybody's vote. Thank you.
Okay, thank you. Motion carries. Next, we'll turn it over to Andrew to hear about the 2025 private pay enrollment analysis.
Thank you, Madam Chairwoman. Board, this is a private pay enrollment analysis that we've done in the past month since open enrollment ended. We always hear Dana Wecker's question in our ear, why does it matter? Or tell us why it matters. So that's what I'm going to attempt to do. So the open enrollment that ended on January 15th was just shy of 250,000 enrollees. For the Ravens fans in attendance, that would fill up M&T Bank Stadium 3.5 times. It was a 16% increase from 1 year earlier, and it was the 7th consecutive year of enrollment increases on Maryland Health Connection, and up 56% total since the pandemic. New enrollments were down 4%, so that might be something that's obviously something to watch going forward. Renewals were up 22%, and we'll talk about that in a little bit too. Private plan, I know a question comes before this board often of sort of what are we doing for the uninsured rate? Private plan enrollments on Maryland Health Connection has grown by 60,000 people in the last 2 years and by 90,000 people since the pandemic. In a state of about 6 million people, 60,000 would be 1%. So by all likelihood, we should have made some improvements in the uninsured rate with the 60,000 that we've enrolled in just the last 2 years. But as we know, the uninsured rate is affected by more than just the individual market, by Medicare, by Medicaid, by employer-sponsored insurance, and other programs. So, if there hasn't been necessarily movement on that rate, there are other factors at play here. Now, one last point I wanted to make on Medicaid to the qualified health plans. We asked, what did open enrollment, when open enrollment closed just before the pandemic in plan year 2019, about 50,000 people had Medicaid before they came to a private plan on MHC, if not directly, had Medicaid at some point. For this plan year, almost twice as many people, 97,000, had Medicaid in the prior few years, and now have private plans. And so the difference there was, it was about 33% of the total private plan enrollment on MHC back before the pandemic. It's about 39% now. So as sort of let's say a gateway onto private insurance, Medicaid has had a big impact. And I think, as Michelle and others have alluded to, we'll see what happens in the coming months, in the coming years. But there should be a lot of change in that program. Any questions before I go to the next slide? Next slide, please, Cynthia. So this was the growth in the blue for 2025, and the uninsured is in the red on the right. And it's hard to do apples and apples because we know what the open enrollment growth was as of January 15th. This is last year. The uninsured rate has a lag to it. So these were figures from the U.S. Department of Health, originated with the Census Bureau. This sort of chart sort of comes from the Rural Health Information Hub. But so there's a bit of a lag. But I think when we're looking at how did we do with enrollment, and did we reach out to the people who need and are lacking health coverage, we compared the blue and the red. And I'd say the pluses for us were the Prince George's, which has the highest percentage of uninsured in the state, and in raw numbers, the second highest, or also very high, was second in enrollment growth. And Wacomico, which is the 5th highest in the percentage of uninsured, was the 3rd highest in percentage enrollment growth. So we thought Prince George's and Wacomico were sort of bright spots in this past open enrollment. A little less so was Caroline County, which has the 2nd highest percentage. You'll see that second red bar to the left on that red side, 2nd highest percentage of uninsured, but was 4th to the last in enrollment growth for 2025. And Garrett is the 4th highest percentage of uninsured in the state, but it was last in enrollment growth for 2025, just above flat, just about 1%, fraction of a percent. Next slide. So the next two slides you'll see is sort of in our thought process of what we're looking for, of sort of how the health exchange performed. And on the left side, that's the uninsured rates, the top 7 counties in the state in terms of uninsured rate. Prince George's being the highest at almost 13%. The middle chart is uninsured populations by raw numbers, and obviously the bigger counties in the state have the most uninsured population, the most uninsured people. So Prince George's has over 73,000 people. And then on the right side was the enrollment growth this past open enrollment for MHC, and Baltimore City, Prince George's County, and Wacomico all did very well. And again, those are important counties for us because they're counties where people have lacked health insurance. And Baltimore County also is in there as well. Next slide. It's just a different way of looking at it. So inside the red circle are the places with the highest percentages of uninsured population, and we've already sort of gone through them. In the blue circle are the places with the most uninsured people. So they might not have the highest percentage, but person per person, they have a lot of uninsured people. And the green circle were places where we had the most growth on the health connection this past open enrollment. So again, Prince George's sort of was a star in that it is inside all 3 circles, the highest percentage of uninsured, the most uninsured, and the best growth on MHC. Wacomico, highest percentage of uninsured, inside the green circle, also had a lot of growth on MHC. And Baltimore County and Baltimore City, most uninsured residents in that grouping, but also had a lot of growth on MHC. So it was just another way of sort of looking at it to say, did we achieve what we had set out to do? Next slide. So I know you've heard in the consumer assistance group, there was a focus on what they called meta areas. And this is looking at the zip codes around the state that had chronic uninsured people, the highest levels in the state. And so, they were, all over the state, from Cumberland to Hagerstown, from Elkton to Salisbury, and in between. And when you look at how we did this year in the meta areas, and that was the connector entities in particular, but all the consumer assistance folks were tasked with sort of trying to do more in terms of outreach, in terms of events, in terms of marketing to these areas. And we had the significant growth in the Dundalk, Essex, Edgemere area in eastern Baltimore County, a little less so, let's say, in the lower shore in Eden and Pocomoke City and Crisfield. But overall, you could see in those blue bars, percent ranges of, 2% and 4% growth in a lot of them. And, we consider that certainly a positive step in the right direction for areas that have historically lacked health insurance for too many of its residents. Next slide. Thanks, Cynthia. And I think Johanna had gone over this, that 3/4 of the enrollees on Maryland Health Connection are either in gold, silver cost sharing plans. And that's extremely important. I think it speaks to what you heard in the prior presentation, sort of like the actions and the toolkit that the state and Maryland Health Connection have used in the last several years in reinsurance and the young adult subsidy, which the legislature is continuing extending this current session, have made these plans more affordable for people, and thus consumers have felt more comfortable and more confident at being to enroll in better medical levels so that their deductibles are lower. So we're not hearing what we used to hear in the initial years, let's say, of the health exchange, which was the stuff is too expensive, I can't afford it, and even when I do, I can't use it because I can never meet the deductible. So I think this chart, the fact that 3/4 of people are in sort of manageable deductibles where they feel they can use it and it's of value to them, has been probably among the best thing I think that the exchange has done in its first decade. And I think we're particularly proud of in this past year. There was never a drop off. In past years, you would see a drop off as people, sometimes they'd drop offs were for good reasons. They might have gotten a job with health insurance and they didn't need us anymore. But in other cases, they were like, I can't afford it anymore, or I don't see value in it anymore. And so during the year, it would slide down. That's not what we saw this year. It pretty much stayed steady for most of the year. Sometimes December will have a bit of a dip as people say, I can save a month of premiums and hopefully I won't get hurt. And, but by and large, it was steady throughout the year. And I think that was very gratifying. Next slide. So this is, we looked at sort of how did, by slices of household incomes, how did we do? And the pluses were the under 150% of federal poverty level population had the greatest growth, substantial growth, 45%, I think. And of course, there was a special enrollment created year round for that population, but it was also a population that has, struggled with being able to get health insurance or afford health insurance. So, that was an achievement. And also the Hispanic population below 138% has grown nearly 50% in the past 2 years. And I think that speaks to the marketing, the outreach, the attention being paid to that community, which also historically had uninsured rates of double or triple the general population. And I think we have, not closed that gap completely, but, we're making inroads toward closing that gap. On the downside, we had a big rise in unknowns, 23%. That's people who don't tell us how much income they have, so we're not able to slot them in sort of an income slice. And it's risen over the last couple of years. So why do we have people not wanting to submit their income information? One thing about data is you sometimes have to question, okay, what is it you're actually seeing here? Don't jump to conclusions. And it could be that the enhanced APTC and the Inflation Reduction Act that reduced the cliff for people over the 400% of the federal poverty level were able to get more coverage than they had before, but didn't feel the need to put their incomes in because they weren't specifically getting the APTC up front. So they may have claimed some things on their taxes later. So we don't know whether there's, more and more people actually surging not to put their income levels in for some other reason, or if it's simply a reflection that, the cliff has lessened and more people above 400% of the federal poverty level are coming in, but not putting their incomes in the application. Next slide. The young adult subsidy is working. Enrollments of young adults aged 18 to 37 grew 21% this year to nearly 90,000. More than 2/3 of them, nearly 65,000, were eligible for a state subsidy. And the General Assembly is considering extending the program through 2028 or beyond. And this shows a little bit of percent change in the young adult subsidy. I think for us, the pluses, Black and Hispanic young adult growth was substantial, below or above 40%, 21% of young adult enrollees, 26%. I'm sorry, let me rephrase that. Among Black young adults, they made up 21% of the young adult enrollees, but made up 26% of the young adult subsidy recipients. So it showed that young adult subsidy was particularly important for their ability to enroll in Maryland Health Connection. And similarly, for Hispanic young adults, they made up 14% of total young adults, but 17% of the young adult subsidy recipients. And again, showing the importance of that tool to help more get enrolled. Among the minuses, there was not much of a gain in new young adults with or without subsidies. So, I don't know if there was a little bit of plateauing effect there or what else, but we didn't make as much gain perhaps as we had in the first years when the gains were even greater. Next slide, Cynthia. And again, speaking to the minority enrollments, with a lot of the marketing focus, enrollment by Black consumers was up 23% by Hispanic consumers was up 25%. Michelle mentioned that was for the first time due to executive order that recipients of the Deferred Action for Childhood Arrivals were eligible to enroll with subsidies through the state marketplaces, and 249 had enrolled for 2025 coverage. Next slide. The next two slides are just sort of what was the commercial? You'll come a long way, baby. So this is what Maryland looked like before the Affordable Care Act in 2010. You can see how sort of dark the state was, and the darker it was, is the more uninsured people living there. So some of these counties, far western, Lower Shore, Prince George's, had almost 20% or more were uninsured. People in those counties, 1 of every 5 in some cases, had no health insurance. But even in most of the state, you can see, generally 1 in 10 people did not have health insurance. Next slide. So this is what we looked like in just a couple of years ago. Much brighter. The outer suburbs are below 6% in the light blue for the uninsured. The inner suburbs and the rural counties were in the 6 to 12% range of uninsured. Prince George's continued to be the highest, uninsured. But the picture is certainly have made a lot of improvements through both the improvements in the individual market as well as the expansion of Medicaid. Next slide. And another thing that we just talked about in the earlier presentations regarding the enhanced federal tax credits, which are due to sunset after this year, and has been talked about, would affect the results next year. And this just shows, this was an analysis done by a Kaiser Family Foundation research, and it shows what enrollees would be impacted. The way they did it was by congressional district. And you can see around the state, there's, 25,000 to 30,000 people in each of these congressional districts, for the most part, who are marketplace enrollees, and 3 or 4% or up to 5% of them, of everyone in the district is enrolled in the ACA marketplace. And without these enhanced subsidies, their increase in premium payments throughout the year would be, roughly $971 or 167%. So in a particularly price sensitive product as this is, you can imagine the impact that could have. So we'll certainly be watching sort of what happens there, and doing all we can to to help and get the word out in whichever way we can. I think that might be all the slides. Do you want to? Yeah, I think that was it. Are there any other questions that anyone has?
Go ahead, Marie. And then Singh.
Thank you. So I think one of the things, Andy, and if you talked about it and I missed it, I apologize, but have y'all done a look at the Medicaid, sort of the Medicaid unwinding counties or zip codes with the highest disenrollment and some of the success we've had? Because it looks to me like, based on the data you shared, we did pretty well with folks who might have been on the bubble of that Medicaid redetermination line.
Yeah, thank you, Commissioner Grant. We had I think the state had amazing success with that. I think if you look at the figures, the roll off of people from Medicaid onto the exchange, where they have largely sort of have stayed, has been phenomenal. I think, if there was a way to sort of get people into Medicaid and then say after a year you might be off it, I think, to me, it said that people, I think since the pandemic, they're more health conscious about sort of what could happen to them and their families. And I think once they get health insurance through Medicaid and realize, geez, this is what I want, to be able to go to a doctor and have my family go to a doctor when they need to. I think when it was time for them to roll off, it was like, I don't want to give this up. So they did heed our heed our outreach and our marketing to try to sign up and get enrolled in, and our help in getting enrolled in the health coverage.
And yeah, and then just maybe a comment. I am super concerned about what the drop in subsidies that happens with no further action by Congress means for our market. So look forward to working with you all and wrestling with that. But I'm very concerned about what it means for the level of enrollment as well as the morbidity of our enrollment that sticks around if those subsidies go away. So more to come.
Thank you, Marie. Singh?
Yeah. The growth we saw in the Black and Hispanic community enrollments were very impressive. My question was, how does that relate to the general population growth in the state? Is it consistent with that, or were we exceeding that, which helps us even have wider coverage, more individuals?
Good question. So it was comparable in some ways. I mean, I think overall the growth was, 20% maybe overall. So it was, but I think for groups and populations that for reasons from affordability to access had not been able to get health insurance or avail themselves of health insurance, I think we were particularly happy to reach communities where we didn't necessarily think we'd be able to reach. But as you saw, the health exchange overall has grown 7 years in a row, and overall is up 56% just since COVID.
Thank you.
Laura?
Thank you. Is there a further breakdown of the young adult subsidy by county or district?
I think we can get that, so we should be able to get that for you. You would prefer it by county or by state legislative district?
By county would be good. I'm just curious to, I think it was Marie's point. Just the concern, is it evenly distributed, or where would we expect the greatest pain if that goes away? And then you mentioned earlier the persistency being something that you were really excited about. Do you have any kind of rationale for why that persistency exists, and is it even across either county or congressional district?
It's been fairly consistent, and no, I think we're just theorizing. I think the fact that it looks so much different this year, and the Medicaid unwinding that Marie alluded to sort of continued into this year. It went to June, and then I think there was still some more effect of people sort of rolling off on things like that. So I'll be curious to see what we see in 25. And of course, as was just mentioned, it's hard to know what the effects of some other things will be in 25, but it was fairly consistent, Laura. I mean, I think month after month, we kept looking at the figures and saying, okay, it's supposed to go down now, and it wasn't. It did not go down, which is why we entered the open enrollment with the highest number of renewals by far that we ever had. And you saw that in new enrollees, we didn't really gain that much. It was 4%, but the renewals were so consistent in signing up again that was a strength.
Does that would contribute to some rate stability from the carriers, right?
No question. I think the things that have been done, like reinsurance, to be able to sort of keep those rates down, as I think Michelle has talked about before, we have among the third or fourth cheapest premiums in the state in the nation for Maryland Health Connection. So I think, and the young adult subsidy, you throw another average $40 a month in reducing someone's bill. It had an impact. But another impressive thought, the data point that I saw was we had growth in the non-subsidized young adult population almost as strong as the subsidized population. So it said to me, with or without that $40, you still had people who said, I want this now, who have come through the pandemic, and I definitely want this health insurance. So I think it spoke to the value of the product that people see.
Because I would suggest then again some more rate stabilization, growth in the young adults, persistency, and maybe lower utilization across the
Yeah,
carrier. So we
the
should
young adult impact on the risk pool and morbidity is important.
right. So that should follow through when we see the submissions come through in the summer.
And Secretary Herrera Scott, if I can just add one other comment, because it's not on the agenda. We didn't talk about it today, but it is important. And we did talk with the Policy and Governance Committee of the board about this. So Kat had referenced at a high level. We are really concerned, as Commissioner Grant said, about that funding going away. The expanded tax credits and the impact that will have. There has been a bill dropped that would give the exchange the authority to use reinsurance funds for 1 year as a stopgap measure to backfill whatever was lost from those expanded tax credits for that 1 year, until the state could figure out, as I talked about earlier, what's our path forward beyond. So that is a bill that is coming through HGO, Health and Government Operations. In that chart that we showed a while ago, it did show at the end of 2028, there would still be some solvency. So we believe that even if for 1 year we had to use some of that funding, it would still allow it to be stable and solvent through the end of the period. But that is just something moving through the process as a stopgap measure to buy us a little time. So we'll report back. As I said, we did speak to the Policy and Governance Committee about this. The bill is publicly dropped, and we'll see what happens with it.
Thank you, Michelle. Any questions on this latest information from Michelle, or any questions about Andrew's presentation or any of the other presentations? Ben, go ahead. You're on mute, Ben.
Andy, when you count unwinding, are those individuals, are they classified as, when they go from Medicaid to the exchange, are they considered new enrollees, or are they considered renewals?
I believe they'd be considered new enrollees for QHP, but I'll double check that.
Yeah. I mean, the 4% does seem kind of strange to me, but I'll take that. Maybe over the course of the next few months you drill into that a bit, but it does seem as though that number seems particularly small given the unwinding that still occurred in the first part of this past year. Thanks a lot.
Ben, just one additional data point on that. If they came over during the year, which is what they did, and then they got renewed for 2026, they would have been in the renewal count, not in the new count.
For 25,
Or
yes.
for 25, sorry, for 2025.
And this is Johanna. I would just add that when we're looking at our year-over-year change in, say, new enrollees, for example, we are comparing to last year when we had strong growth in new enrollees because of the enhanced premiums, because of the unwinding. So the year-over-year change may be small, but that's also, I think, in part because our baseline of last year was strong as well.
Thank you, Johanna. Any other questions for anyone or from anyone? Okay, hearing none. That formally concludes today's board meeting. There's no closed meeting required. So with that, unless there's any other questions, I'm going to formally close today's meeting. The next meeting is April 21st. There's no meeting in March. So hopefully we'll get past this cold spell and start to head into spring. And I wish this commission and everyone on it good luck in figuring out what may be a very complex situation depending on what happens in the federal government. But thank you all for your service. Thank you all for your support of me in the role, and have a great day. Thank you, everyone.
Thank you, Secretary.
Secretary, I want to thank you for your leadership. It was a good 1 year we were together. Again, thank you.
Yes.
Bye, everyone. Have a good afternoon.
Thank you.